Everybody, this is Professor Butler, and this is going to be the section on pediatric assessment specifically. The part on interventions is already recorded separately, so please look at that one as well. So let's go ahead and get started. So, first, let's talk about growth and development of a child in general. Growth and development is one of the things that we monitor throughout their different ages and stages. As adequate growth and development occurs, a child will mature and be able to adapt and function in more complex situations. Growth is considered the quantitative increase in size and weight. So, those are the numbers that we get when we weigh them and measure them. Development is an overarching term related to their abilities, skills, and social learning. Maturation is basically being able to adapt and to a higher functioning. So, going from simple to complex. So this picture right here, this picture shows the growth patterns. So when we say cephalocaudal, that means they have a head to toe approach, and that's typically what we like to see. Proximal distal is from center outward. This also, the way that you can understand it is that both sides should be having equal growth. So we shouldn't have one limb longer or growing faster than the other. That would be considered abnormal. So think of it also this way. This is how I describe it. Cephalocaudal means the child should be able to control the from the top to the bottom. And if you think about it, it makes sense. So the first thing is they get that head control, that neck control. They'll be able to lift their head. They're not able to, get up into a crawling position. So they have the head control, then they have the trunk control, and then they're able to balance a little bit of their trunk and not fall over. And then they're able to sit independently. Then we get up on those knees, right? And we might be crawling a little bit. And then eventually the child will learn how to walk. That's that cephalocaudal growth pattern. The proximal distal is, like I said, equal size, but we also need to look at not necessarily equal length and distance and growth and strength, but we also want to look at skill wise. And so these are the things that we look at because it can point to there could be something going on with a child if we're seeing one side not growing versus the other side, um or if we're seeing, they're able to not really control their head by a certain time, and you'll hear these things again as we go through ages and stages. All right, so I think I've already talked about this next one. So this is just another slide laying out the years. So when I talk about school age, toddler, infants, and so forth, moving forward throughout the semester, we know exactly what we're referring to. So this is the growth, well, not sure, sorry, the growth, sorry. The screening thing I told you from the American Academy of Pediatrics. And this, I believe, yeah, this is the most updated one. Now, I want to put a plug right here and let you know that we are going to really be using a lot of the recommendations from the American Academy of Pediatrics, AAP, because the CDC was originally our go-to for a lot of stuff, and it still will be, but they are cutting back and not recommending certain things that are really important to the vitality of a child. Therefore, um, especially when we get to communicable diseases, I may not be using the CDC recommendations, okay? And neither is the textbook as well. We know what is safe for our children and what's highly recommended, and the American Academy of Pediatrics has stated that since certain things were removed from the CDC recommendations, like for immunizations and so forth, they are not in support of that. And a lot of pediatric professionals are not as well. And so we're going to follow the textbook and we're going to follow the American Academy of Pediatrics. So more to come on that one. But this is the latest and greatest. This has not changed. One thing I want to point out is that the top row and the bottom row. So the top row, you see the word history and you see the word anticipatory guidance that we talked about on the first day. So both of these are things that are happening before birth So before they even come into this world, so you see the word prenatally. And these are things that happen obviously as they go all the way through to through adolescence. So my point is, this is something that we do all the time when it comes to approaching care for a child. You know, looking at the prenatal care, what mom has done, has been exposed to, and so forth. That's really important that we look at that um, even beforehand. And then the rest of them, you'll see these are the recommendations and when you start doing certain things. So obviously, we're always going to get vital signs. We're always going to get their numbers. Blood pressure, as I told you originally, that they will say in some textbooks that we in our primary care that they really start taking the blood pressure at age 3, but here American Academy of Pediatrics understands that we do it regardless throughout. All right. Um, and then going down to when vision starts, when hearing starts, when certain screenings, behavioral screenings, suicide screenings, tuberculosis screening, lipid screenings, all these different things. So this is not something that you have to memorize. This is something you can refer to. But it's just to give you an idea of all the type of screenings that happen throughout their different stages, as you can see. All right, next one. So still talking about developmental screenings. That list, that chart that I just showed you had all types of different type of screenings that we do. Some are categorized as risk screenings, needs assessments, early intervention, and so forth. Uh, the big thing I want to show you here is that we have different type of tools for different things. So they may recommend a specific type of screening, but there are different type of tools that can be used to do those screenings. And this is a screenshot of Bright Futures, which is one of the main go-to websites that we use to locate tools or assessment tools for particular types of screenings. Like see here, oral health. It has 3 different tools that you can use. Usually institutions that you work in will have a particular one that they want to use. You always have to use a tool that can always be translated into someone's native language. So that's why you see a couple of them here, double with Spanish or English. Okay. So the toolkit from Bright Futures is like the number one website that we use to find different assessment tools. Um, what I also want to show you is the main one that we use as far as the global developmentally screening tool, and it's the ages and stages. So in mental health class, you probably heard of the Denver tool. That was the original tool that we used to use a long time ago, but unfortunately, it's not specific enough to be able to accommodate children with developmental delays, who may be just a little far behind or a little ahead or whatever case may be. It's really rigid and it's like the average child should be only one that should be fitting into that. And that is not something that is used in hospitals. In fact, the Children's Healthcare of Atlanta, they have used the ASQ as our initial screening tool when somebody comes into the hospital for admission. So highlights the strengths and the concerns. It's very specific. It's age specific questions to address physical, language, intellectual, social, and emotional development. Very great tool. So you need to know that this is the go-to tool for pediatrics and is highly recommended. On the next slide, you will see a video, and you're more than welcome to watch this because some people, are interested in pediatrics and they just want to see how this is applied in practice. And it gives you an idea, oh, this is what it looks like. Oh, this is how this is done. Because children can be kind of tricky. So you're more than welcome to click on this and look at this. It's a very brief video to show you how this is done I believe this is in a school because she looks much older than she doesn't look like daycare. But if somebody has any concerns about possible delays of a child, they can use this to kind of see where they are developmentally, because we might need to put in some early intervention methods or referrals actually, so that the child can hopefully catch up to their age group. All right, now we're going to talk about some specific screenings. So we're going to talk about the eye slash vision, right? This is a formal screening tool that we use. And we typically, if a child who's born, who doesn't have any type of prenatal history where they had to be in the NICU for a specific time or anything congenital, this usually will start at age 3. If we're doing assessment and documenting their vision acuity or their vision in general, obviously we're looking at their eyes. We'll talk about that in a second, but we are also looking to see if they track. That's the big one. So when a child gets to a certain point where they should be able to track, I would say like about 6 months or maybe just a little less than that. But 6 months is usually a great time when you have a toy that's really bright and colorful, and you just move it over from left to right very slowly and see if once you get the child's attention, obviously, and then see if they are able to follow that toy across. Now, here's a big one. Yes, so might be able to lock on and look at the toy, but we want to see if their eyes are going to follow it. And then you also want to make sure that they are tracking across the midline. So the midline means, think of a line that's going to just going straight down the middle of you. And children who are developmentally delayed may not be able to track across that midline. That is a sign that there is a developmental delay. So you might start over here to the right, get to around their nose, you're going past their nose, and then all of a sudden they're not tracking anymore. So that is not a good sign when a child cannot track across the midline. So when we're doing an assessment, first we're going to look at just, look at the eyes, right? You want to look and see, are there any tags? Is there any drainage? Any redness, stuff like that that we would normally do. Okay. Um, and then we're going to check ocular alignment. There's 2 tests that we do for that. It's called a cover test, and the big one is Hirschberg. You can see I put 2 stars by that, so you might want to put a star by that. And I like the Hirschberg's test, and we used to do that when we did assessments as one of our community thing because it's non-threatening because you stand away from the child. You basically tell them to look at a light and you shine a light and they look at the light, and you're looking to see whether or not the light is shining in their pupils equally. And I have a picture of that in a second. When they get to a certain point of age, like age 3 or older, we want to use the vision acuity. We all know the Snelling chart. That is the main one that you definitely want to use. Typically, you might want to really start the Snelling chart around age 6 or older, um, because they might not be able to tell you their full alphabet at age 3. Some children probably can tell you. If they can, and you really do need to do a vision test, we have the HTOV, or we have what we call the tumbling E. So this is the tumbling E, and this is the HTOV. So the tumbling E is basically the child will say, they'll point which way the E is pointing. And so they don't have to identify the letter, but they just need to tell us, is it pointing down? Is it pointing this way? Is it pointing that way? And that tells us that they are seeing that object. But going back to the ceiling chart, is commonly used consistently for ages 6 or older. Again, we will typically start at age 3, especially if we think there's a problem. For anything less than that, we can use the HTOV or the tumbling E, or if they have any cognitive impairment and they're over age 6. If a child gets less than 4 of the 6 correct, they will need to be referred for more testing. We also test their red reflex and peripheral vision, which we've all had that done. So this also applies to children. Again, I like to give you some visuals. So if you want to see what it looks like to do an exam on a pediatric patient, you can. This is not required, but it's there if you want to look at it. So let's talk about some of the vision impairment things. Causes. So children, especially infants, can have a vision impairment from exposure to a sexually transmitted disease like gonorrhea or chlamydia at birth. This is why we put the erythromycin ointment in their eyes to kind of protect them just in case there's any type of STD or any type of bacteria when they're born. So it could be due to an infection, rubella, syphilis, and toxoplasmosis is another cause. They also can have ROP, which we'll talk a little bit more in cardio because that has a lot to do with oxygen toxicity. Trauma, obviously, there's something trauma. I've actually seen newborns with cancer of their eyes that's not there, but I've actually experienced that. It was so sad. Um, and so cancer can actually take their vision at a very, very young age. All right. And so, excuse me, know the different types of classifications when it comes to visual impairment. We've got partial sight or partial visual impairment. That's an acuity of 20 to 70 or 2200. And legally blindness or severe impairment, the visual field is less than 20 and the acuity is less than 2200. Um, Also, before I go into caring with a child with visual impairment, I just want to point out some terminology, and I have some pictures for them there. Um, and on the next slide, excuse me. So astigmatism. Astigmatism is very common. It's the blurred vision, so they can't really see things because their eyes aren't working together. And so you can get glasses. In fact, I have that personally myself. And when I put my glasses on, my eyes don't strain as much. Um, Nystagmus is that rapid eye movement, either left or right or bilaterally. Amblyopia. And wait, I think I'm saying amblyopia. I think I'm saying that right, but lazy eye. Okay, lazy eye. And strabismus. So one is a lazy eye where one of them is lazy, or you can have bilateral, or they'll be cross-eyed. So just let's take a look at the next, and I'm going to come back to the care in just a second. All right. All right. So here you see this child. Well, I'll tell you this one. So this is one is a lazy eye, right? And then this child is cross-eyed. And this is all about alignment, y'all. So we have to identify this early on so that we can actually fix it. We use the patch technique. And so what we'll do is put a patch on the strong eye, and that makes the weak eye work more and get stronger. There are some surgical corrections that can happen as well. Um, but the earlier you do it, the better, because if not, they're really going to have some vision impairment later on. This one, I want to show you that, remember I said the Hirschberg's test? So this eye looks like a little bit of a lazy eye. But if you can see, and when we're shining the light, it does look like it's equal in both eyes. So we would probably look at that and say, hey, looks like they have a lazy eye, but it looks like it's shining equally in both eyes. So anyway, I thought that was a really interesting. So let's go back to talk about care of a child with vision impairment. It always, anytime a child has an impairment, when you're caring for them in a hospital or just in general, even out of primary care, it's important to orient the child to the surroundings. We want to make sure the environment is safe because they have a vulnerability to hurt themselves or run into things just simply because it's a foreign place. Always important to encourage independence. So this is where support groups will come in. This is where you might refer to certain organizations that can connect them with services and different things to enhance their ability to able to function in the society as normal as possible. Consistency of team members is like primary care nursing if they're in a hospital, or just a medical team that really gets to know this family and this child's needs and it can really advocate for them and understand what they truly need. Promoting independence through play and socialization and not isolating them. So they still need to go to, group play, right? They still need to go into the school. They would need an IEP or an IHP that I talked about before where they might need to be sitting in a specific part of of the classroom depending on their visual impairment. There might be a special school that we can advocate for them to get into. Maybe give them special books, special adaptive equipment, whatever is needed for them to be able to develop optimally and also integrate into society as normal as possible. The tapping method. So I have a picture of a tapping method in a second, but tapping for both vision and hearing is a way to help them learn how to calm themselves. They can start doing it to themselves as they get older and understand that this is a way to calm them when they have sensory overload, because they're at risk for sensory overload. Because when somebody has a deficit in one sense, the other ones are um, turned up, and so they can have an overload of senses. And sometimes this is we can see it as a behavioral issue with a child simply because of the constant stimulation that's driving them crazy. So tapping is a way that we communicate calmness to them. And I wish I was in front of you because I can show you, but you can tap them or you can tap next to them. And the rhythmic function of tapping is really a neat way to do it, to teach family members and to teach the child that you're here for them, even though you can't see me. All right, so let's keep going. Hearing. So, hearing is another screening, obviously. Hearing starts before they leave the hospital. There are some children who have increased hearing screenings because either one, they received antibiotics after being born, or they had a extended stay in the NICU, especially if they were premature. So when we are doing a hearing screening, obviously we do want to look at the ear. We want to look and see if there's any tags. Like this child right here has a ear tag right there that can easily be removed. You want to see if there's any drainage, any bleeding, any excessive wax that you might be able to visualize before you're actually looking in the ear. You want to see if the pinna is lined up with the orbit of the eye, as you can see in this picture with this boy right here. You can look at that much younger because that's one of the signs that says that this child possibly has a congenital disorder. All right. So if the degrees, if this was, oops, get my cursor back here. So if this was lowered, for it so to speak, and it was more of a downward slant, then that means that the child probably has what we call low set ears. And if they have low set ears, we probably need to do an evaluation because there could be something genetically going on with the child. So we're gonna look for any tags, any drainage, redness, etc. We're gonna look for alignment. We're gonna look at the pinna, and we're gonna look for any pits and opening and so forth. Inner inspection now. So that was the external inspection. So for the inner inspection, we're going to obviously shine a light to look for that excess wax as we're going in. Look for any foreign objects. Believe it or not, kids love to stick things in their ears. Actually, that's one of the reasons why sometimes they have trauma to their ears. And then we're going to go ahead and assess the tympanic membrane. So when you are doing that, it depends on their age. So for children who are less than 3, you need to pull the pinna down and back. And for greater than 3 years old, you need to pull the pinna up and back. So down and back for less than 3, as it says here on the slide, and up and back for ages greater than 3 years old. Make sure you know that. Okay. And the reason why is because we can't really see the tympanic membrane without doing that maneuver. Obviously, when we get older, they don't necessarily have to do that with us because it's easily visualized. But for children, we do have to pull up and back or down and back. And we're going to talk more about otitis medius later on when we get to, I believe, respiratory ear infections, because it's a part of the whole respiratory thing. All right. So the auditory testing, the bears testing, is the test that we give to children before they are discharged. So this is a picture of this little beauty here who is getting a bears test. They have to be sleeping and rested. So we typically will do it after they have a feeding. And it's a simple test that just lets us know that whether there's possibly some hearing issues. It's a brainstem response, and so they have probes on their scalp, and it just picks up whether or not um, there is any, response to the hearing, to the sounds that go on in the ears. So I don't know all the details, but the Bears test or the ABR test is a mandatory test that is done before discharge. Now, impairments for hearing causes can be prenatal or postnatal, meaning these are, let me see, some typical causes. You don't have them listed, so I will share them here with you. We can have children who were born prematurity. So when they're born premature, they are more sensitive to the sounds. They don't have that buffer being in the wound. And we literally can damage their hearing just sitting and talking really loud by their isolate. Okay. Um, and their ears are very sensitive when they are born premature. There also can be some perinatal infections. There also could be some due to some substance abuse by the mom. If a child has postnatally, if a child has a lot of ear infections, it actually can affect their hearing. And cerebral palsy is usually connected to some hearing impairments as well. All right. And then also forgot one very important one. I'm so sorry. Genetic history. Sometimes people are born deaf, and this is something that could be genetically passed on to their children. So there are different types. We got conductive hearing, and sensory neural hearing loss. I've listed here where the hearing loss is located. Um, is usually caused sometimes by an infection. So if you fix the infection, then you're not going to have any issues, or they might need to wear hearing aids. Sensory neural loss is an auditory nerve or inner ear problem, and usually they probably have to have a cochlear implant. It also can be kind of a mix, and this could be caused due to reoccurring ear infections with massive complications. All right. So, caring for a child with hearing impairment, obviously, you got to have good hearing to be able to form good language. It's very important that they work with speech, language therapists, development of their language. Learning sign language is key. Putting all these adaptive things in their hands and for them to learn and the family to learn in order for them to really have the optimal development that they need to maneuver throughout society and in school. Okay. So there's a lot of things listed there that I know you guys already know. And socialization is one of the things too for their social development. EFT is that emotional freedom technique. That's that tapping method that I talked about already. Again, this really helps them learn how to center themselves and calm themselves. And this is something that we do also to them to help them know that we are here to help and not hurt. All right. So, screening for sensory impairment in general. So, we already talked about some of these. So, we've got the hearing screening. We're going to talk about the cardiac screening and cardiac. We have a blood screening, which is called a metabolic screening. You're gonna hear me talk about that throughout the semester, mostly in GI, because metabolic disorders fall under GI. But here I want you to know that there's a lot of screening that is done on our newborns. We've got the hearing, the vision, the blood tests for checks for metabolic disorders, and also some genetic disorders like cystic fibrosis, sickle cell, and then the cardiac screening is looking for cardiac anomalies. All of these things are done before they go home. So all these things are look to identify possible problems so that we don't send these children home at risk for a sudden death, for example, or a lack of development and resources in order to develop properly. And so all of these things are really, really important that we do in the beginning. And it's just textbook and natural for us to do. But the big thing is our management here. Early interventions are key. These children, if we find that they have an issue, we can put in place early interventions to promote development, attachment, support the family. It's going to be a very difficult transition time. There's going to be a grieving process that the family goes through because they don't have the normal child that they thought that they were have, and all this therapeutic things can be put in place early, and it's going to be so beneficial for this family moving on. And if there's a need to do some genetic testing, because a lot of people may not have known that this could possibly be a genetic thing, and so they can make informed decisions for future births. All right, so the next few slides, I'm really just talking about communicating with families and children. I'm not going to go through everything here. This is something that is very difficult for a lot of students. I have I should say grade highlighted some key things that I want you to take away. So I kind of will focus on them as well. Communicating with children and families is it's a challenge sometimes, right? Because you got to get on their level, but then you're trying to talk to the parents. So you're kind of like having two different conversations. And that's very true, depending on their age. So listening is key. You know, we want to get in, we want to do our job, we want to get out. But sometimes spending time and just listening to people is really, really important. And being culturally aware of your potential biases, because we all have them, and what are some of the things that might be important from this family with whatever known background that you have from them from report? So using silence and not judging them, because a lot of times families are doing the best that they can, or they may not even be aware of some of the things that they may not be doing correctly. And this is where we step in. So we don't want to put up blocks and barriers to communication. So here are some common communication barriers, and these are signs that from parents that or from families that you're I need a break, right? I'm overload. So common barriers is giving unrestricted and sometimes unsought advice. Right? You're coming from your point of view and not getting taken time to understand their point of view. I've done it and I've heard it done a lot. Stereotyping them, limiting expressions of emotion by asking directed close-end questions. We all know we need to use those open-end questions. Talking more than listening, and then forming prejudged conclusions. And that can sometimes form at report. And we know this can happen in the adult world. We got that patient in room 5 again. Oh my gosh. Oh Lord. Oh no. But, sometimes you have to, maybe this time it's going to be different. And sometimes literally the person that walks in there who has a positive mindset, they can feel it. And then your experience is not the experience that they describe in a report. Signs of overload, sudden interruptions, asking to just do something else. They start looking around, frequently looking at the watch or clock and attempting to change the topic of discussion. Or just really, sometimes parents can be very blunt with you. Now, I think, communicating with children, this one is something you probably haven't heard a lot about. So the ones I just talked about before, I know you talked about this type of stuff of interviewing and how do you talk to people and so forth, because that's an adult to an adult situation. So you've had that, but let's talk about communication with children. Obviously, everything is based on their developmental stage. If you can use play when appropriate, that'll be great. Use a creative way to get them to open up, establish trust, pay attention to their behaviors and reactions, and not just when you're talking to them, but also when you were talking to the adults, because they might show you cues to certain things the family says that you're like, okay. And if you want another opinion, that child life, social work, we also have family experience liaisons who can sometimes come in and help, get a second opinion of what's going on in this room. This is box 4.3. So this is the kind of the heart of some of the things that I don't even realize that I just do naturally when it comes to talking with children. So these verbal techniques here are listed in your book. and some I use more than others. So like the I message, um, I'm concerned about how treatments are going because I want to see you get better. All right. And the way that you approach them is I or you. And you don't want to do the you because they're judgmental. Again, you're that person that will start to internalize what you're saying. So then you flip it and you're like, you know what? I think I'm really worried about you. Can you tell me more? Because I really want to see you get better, and I want to see you go down to the thing. I want to take you actually. What do you think? Right? So it's like putting it on me. You describe the effect of the behavior they had on the person. Third person technique, I haven't really used that one a lot. Storytelling, I have. And this is really good for children who are younger, right? So the storytelling, letting them draw a picture of their feelings, letting them draw a picture of what is it that you're most worried about, or what makes you happy. Draw me a happy picture, or draw me a sad picture. And then if you can't really figure out what it is, can you tell me more about this picture? Right? So these are things that you can do to allow a child to express. And I'm going to stop here and give you a personal example. When my father passed away, my daughter and my father were very close. And and she was young, she was still in elementary school, and one of the things the psychologist did at her school, they would have her Nina come to her office, and she kind of had like a regular time that Nina would come to her office, and they would talk. And so she had that therapy going on, and she would draw her pictures. And then later on, they gave me the pictures, and one of the pictures was she kept drawing pictures of the funeral, and she had like little stick people, the best that she could draw them, and then she had teardrops coming down all from the people's faces. And that was her way of working out her emotions of losing her grandpa. So, and it really helped her process what happened because, nobody really was talking to her. She was the only child born at that time, the only little one, and she had no one really to talk to, but, and how to deal with her feelings. So that's a really good thing for children to be able to, do you understand what's happening here, or do you want to draw me a picture? There are other ones. What if? I use what if all the time. So what if? I'm always posing a question. What if? To children, and so that's one of my go-to things, right? But there's other ones too. So what I want you to do is not memorize these guys. I want you to just take them in and just kind of be familiar with them, and then put a few in your back pocket to take with you when you go to clinical, because I think that these will be helpful. Communication will be on the test, right? But these are questions, if you read this and you understand it, you should be able to answer the question. All right. So when we are approaching, now we're going to turn to assessment. So we talked about the screenings, we talked about the communication, these things that you have to have somewhat have before you go into the room. But what are we going to do when we get in there? So we need to do a history. So the ones in red are some of the things, again, I'm kind of just putting out there. So we have a history. So you want to know who you're talking to, right? So you always should record who you're getting this information from. Note the family structure, and if everybody's not there present, you need to ask, right? So, do they live just with you, or is there anybody else in the household, right? And then they'll tell you. Are there any family? If it's a single parent, you can say, "Hey, do you have any support system?" This is very important information. And then you want to go, like, what's the real reason you're here? Birth history is a little is different than a past history, right? So for children, they could be like, well, they're only 10 days old, right? So we want to know, hey, what happened at birth? Did they stay in the hospital? Did they have to go to the ice? Did they have to go to the NICU? What was the gestational age that they were born? Um, what was the gestational age that they were born? These are things that you want to ask, to find out, was there possibly some issue when they were born? Meaning, did the child possibly have some delay getting born, lack of oxygen, and so forth? immunizations and exposure to communicable diseases, allergies, diet, social history. Social history, obviously, this is for a little bit older. What kind of friends are they hanging around? What is your impression of those friends? Are they in sports? Are they active? Are they withdrawn? Stuff like that. All right, so you get the picture there. So here is just a list of a whole bunch of different things that we could ask about. So, and then we go down to the review of system. Review of system is, if have you had any problems in any of these areas when it comes to the child and or the family history. And then we have this physical assessment video. So this is, I chose the toddlers since they can be the most challenging. There are others that are available through the library. So this is a video that is available in the library, and the um, toddler video is about 20 minutes. And I would like for everybody to please watch that to get a nice sense of how it is you actually approach a well child assessment. And there might be some things that you might see a question or two from the test about this, but it also just gives you some idea of what to look for. If you don't look at it, that's fine. But I think it's a good visual for you. All right, so exam sequence. So you always want to start for infants, you want to start from the least threatening. Parents can continue to hold the child. This is also applicable to the toddlers if they want to sit in their parents' lap. You want to listen to the lungs and the heart and the abdomen first if they're calm, and do invasive traumatic things last. Okay. Always incorporate play into this, especially for our toddlers. Assess for readiness for certain things. And always, don't necessarily force them if it's not really necessary. Okay. Um, Head to toe assessment is okay, but you always want to examine areas that are at issue first, like what if they're having respiratory issues. Be sure to use a simple language, pay attention to their temperament, look at the child and speak to the parents as well, and give choices if appropriate. And always have the lollipops and the stickers ready, y'all. They need to be praised and encouraged for doing a great job and getting through the exam. All right, measurements that we take. Height is height versus length. All right, so height would be done when a child is able to stand upright using a wall or a scale. Length is when we have to lay them down because they're unable to stand nice and tall. So we could use a device that they're laying on. And as you can see there in the picture, if we don't have that, then we can use a tape, and we would basically make two marks, one at the head and one at the heel, then allow them to get up, and then we just measure between the two lines with the tape, measuring tape. Weight obviously is something that we do need to do. We use scales for consistency. Always try to use the same device. BMI is still listed here as a measurement because it is something that is still recommended. And we start BMI at age 2, measuring it at 2 years old because of childhood obesity is still such a problem. But it's slowly getting some negative looks at it because we don't think it's a good indicator of obesity or being overweight. Head circumference is measured with the tape measure, and it's up to 36 months old, so 3 years old. We do not stop measuring head circumference until 3 because that is when brain development ceases. So we're going to do measurements for head circumference up until that time because we're looking at brain growth. Make sure you measure along the eyebrows and the pinners of the ear, and it has to be a flexible object like a paper measuring tape. All right. So those are our measurements. And then we take those measurements and we plot them on growth charts. All right. There's tons of growth charts. You can get growth charts from the CDC or the World Health Organization. Those are the two that we use. The ones I'm about to show you are from the CDC. And so, depending on what you're measuring, depends on what chart and the age of the child. So, the growth chart will say the years at the top and either length for age for weight, head circumference for age, or weight for length, and so forth. So, you want to make sure you're getting it. And also the sex of the child. So, the blue are for the boys and the pink is for the girls. So, let's take a look at one. So, up here, for example, you'll see. Um, Birth to 36 months. So this is birth to 3 years. This is for a boy. And what we're measuring is head circumference for age, all right, and weight for length, percentiles. And on these growth charts, as you can see, you have this curve. So this is the head circumference to age, and this is the weight to the length. And then, so we're going to chart Charlie, who is 21 months old and he weighs 10 kilos. His length is 80 centimeters and his head circumference is 48 centimeters. And so when we plot them, we want to see where he falls on this curve. So let's take a look. So here's Charlie. There's his numbers. And it looks here, Charlie is in the fifth percentile for head circumference and age. And then he is in the 25th percentile. See number 25 here? He's in the 25th percentile for weight for length. So he's doing good. The thing about these growth charts is that if we would say somebody is at risk, if they are 95% or higher or 5% and lower. So these are our children that we would monitor much closer if we see that they're falling below the curve or way above the curve. It doesn't mean that once they fall, if they have that initially, that there's a problem. It just means that we need to monitor their growth and development because they can either catch up or things could happen and they actually slow down on their growth and their age catches up with their fast growth. All right. So it's very, very common to see that. But again, they probably would have them come and get, if they're really low on the chart, they would probably have them come in a little bit sooner just to check a weight and check a length just to make sure that they're growing and striving well. All right, now growth charting in children. This is a video. This is a video. This is a doctor, and he does really good videos. And I love watch this video. I watch all the videos before I give them to you. And this is really good and kind of talks about the well child checks in children. Again, a recommended video if you want to look at it to see it in action and see it from a different perspective, because I want us to be able to practice this in class. So I'm hoping that we get an opportunity to work with those growth charts. We may not be able to do that until we're in Pete's lab, and we have more time to actually use these different tools. But again, you can watch this video and see what it looks like more closely. Not recommended because we are going to play around with it again soon as well. All right, we talked about the vital signs already, so I'm going to go past these. And we're going to jump into our fifth vital sign, which is pediatric pain assessment and management. So there's a little bit of a section on pain because pain can be a little bit tricky when you're assessing for children. Um, so first of all, there are some factors that influence our perception and measuring of pain. The first thing is their age and gender and what is physiologically going on with them. Their ability to cope, their previous experiences with pain, the parental perception and the parental support in helping with the pain management. And I will also tell you, the healthcare system support is a big one as well. Healthcare systems, some providers do not believe that some children are in pain, or they don't, or should I say, they don't manage it well. That's the best way they don't manage it well. And when that happens, that can cause a lot of different things that I just talked about. Their previous experiences, their being able to cope, and depending on their age, it could also be devastating to them. So, um, We have different types of pain experiences, acute versus chronic. We all know, I know you guys know that one. Um, but the management of it for peds could be a little bit different. Looking at the child's cognitive level, and I hate to tell you guys, they say that the boys have a harder time with pain than the girls. All right, the ABCDs of pain management. This is not necessarily the five rights. So I'm going to kind of explain it a little bit better. So you want to be able to choose a good assessment. We have different tools that we're going to talk about, and when you're assessing pain, you need to make sure you use the right tool for the right child and the right reason. You have to believe that a child has pain. There is a difference between pain and discomfort. A child could be uncomfortable. So you kind of have to look about what just happened, right? Is there a reason for them to be in pain? Is this all of a sudden? Were they doing something like they just ate and all of a sudden they have horrible gas? Or they could be refluxing and we have to give them something for that. And so we don't necessarily need to give them an opioid, right? It could be that they just need some Prevacid or they need some Gas X or something like that, or would simply be repositioned. But you get what I mean, right? We don't always have to throw drugs at something. We need to look at it. And children have a hard time articulating to us. So understand the difference between true pain and discomfort and the different ways and the techniques that we can use to make them feel better. And we'll talk a little bit more about that, other things that we can do in a second. Communication is clear and concise and patient focused. All right. What is it that you're going to do? When are you going to do it? When is it going to be reassessed? And then when we discover this, we need to do something. We can't just ignore somebody whose heart rate's through the roof. Oh, that's not true. It's just normal or whatever. No, we need to do something. We have to do some type of intervention. And then we have to follow back up, reassess and evaluate it. And then if it's not corrected, then we need to do another intervention and believe that this is true and reassess. All right. You do need to make sure you have the right person, the right med, the right dose, the right time, the right route. You need to make sure that you do document this and make sure it's for the right reason. So you're giving the med for the right reason. So are we having pain, anxiety, discomfort? What is it really that's going on here? And then make sure they have the right response because sometimes we give stuff and didn't quite go the way that we thought it was going to go, right? So always make sure you have a right response to a pain medicine. So I'm going to start talking about our infants. Infants obviously cannot tell us they're in pain, but they have unique ways of doing that. And we've discovered certain things that they will do that says, oh, this is a child who's in pain versus a child who's hungry versus a child who has gas. Well, gas could be kind of discomfort too. But this is a picture or drawing that's all over the internet. We have this drawing everywhere. And this is this child. And this is a child who, of a real child. And they look kind of identical as far as their facial expression. So the brows are drawn together and lowered. The forehead is bulging. Their eyes are always squinted, tightly closed, and their cheeks are raised. And their mouth is open and they are making noise usually. All right. And so that is a typical facial response when it comes to pain. They will cry vigorously and they will be restless. So that's one thing there. I will tell you if a child is unable to, especially an infant, is unable to sleep or rest, then that something is definitely going on with that child. Um, and if we don't really do stuff with, well, let me back up. I'm gonna reword that one. In the neonatology, in the NICU, if we don't take their pain seriously, after a while, especially with those premature children, they start to have what we call pain syndrome. And this has been researched and it shows that they start to anticipate pain by 6 months. So we haven't even done anything to them. As soon as we touch the blanket, they start crying because they're so used to every time somebody comes near them, they're going to be hurt. And hurt means not necessarily an IV stick. It means those finger sticks, heel sticks, those are very painful to them. And we just keep sticking them and sticking them in their heels and opening it up and doing it again. And that's painful. And so that's one of the main pain things that they receive in the NICU. So, crying is the most accepted indicator of pain in infants. But we also need to look at their facial expression. We need to look at how they're resting. We need to look at different things, especially our infants, because it's very difficult to know when they are actually in pain. And this is the population that mostly gets ignored in pediatrics. So let's look at our tools. So we have different type of tools. We have observational tools, also called behavioral tools, and then we have self-reporting. Self-reporting is the ones you know the most. So those are on a scale of 1 to 10, for example. So we have that, the numeric scale. Tell me how bad your pain is. This usually is good for school age children and adolescents. So I would say like around 6 or older. But even in that low end, you really kind of have to make sure that they understand that number 3 is less than number 6. Okay. If you have any question about it, then you might want to use the other self-report scale and you want to use the FACES scale, which is underneath. The FACES scale is works beautifully, but you have to orient the child to the scale first. And they'll be able to point to the face. You don't use the face to see, like, does their face match up with number 4 or number 6? No, you have to give the child the scale and say, so for example, you see this face right here? He's smiling. He is not, he's happy. There's no pain, no owies. And then see right here, oh, there's just a little bit of owies that's kind of hurting a little bit. And so he's not smiling anymore. And then if you see, we go up here where they got a frown, and this one, oh my goodness, is crying. There's a lot of pain, lots, big owies. So now I want you to point to the face that you are, and you pause and they will look at it and then they will point directly to what they are. It works like a charm. It works like a charm. All right. So those are the self-reporting pain scales. And for the faces, like I said, I don't know if I just said that you want to, that usually starts around age 3-ish, that you could start using that one. All right. So now let's talk about the observational scale. So the flat scale is the one I used to have another one I showed, but they don't use it anymore, even though I really love that scale. But this one is the flat scale, and they have these different categories. You have the face, the legs, the activity, the cry, and the consolability. And you give them a score from 0 to 2, and you basically will look at them and you observe them and see where they are on this scale. And you give them a score. So that could be anywhere from 0 to 10, right? So the thing about this scale is it's best used for children who have no limitations in their movement, right? So they can't have any type of um, paralysis, right? They can't have any paralysis or be on medication that limits their ability to actually move. Um, and it's also great post-op. So once they come to and their sedation is wearing off and they can't really tell us, we can look at their face, their legs, their activity, their crying, their consolability, and give them a score. This is a reminder that when you're assessing anybody on a scale, you want to always do something if it's 4 or more. 4 or more. That is the universal indicator. If somebody gives you a score of 4 or more, you have to intervene. All right. And then reassess. So the ones for our infants and our neonates, these are specific. So I've given you two, which are cries and nips. So cries is for our infants, and then nips is for our neonatal. Very simple, right? Again, these are specific to whatever indicator, and then we have a point scale to the right. And you just kind of read through it and you would score them appropriately and then intervene as necessary. You will not have the scales on the test, but you will. Well, let me just rephrase that. Oh, why is it doing this? So sorry, y'all. Go back. You will not have the scales on the test, but you will Like you won't have to score because you can't score somebody you can't see, right? Or you can't talk to. But you do need to know which scale or which tool would be used in a specific situation. And you should be able to choose it and be able to say what you would do next. All right. So choosing pain medication. So there are some common pain medications that we use. I'm going to go over them, and we have a new term that you probably aren't familiar with called adjunctive. I don't like this new term. We used to use, the book changed it from co-analgesics. Co-analgesics. So if you have an older version of the textbook, it says co-analgesics. But before we do that, I want to talk about I want to point out about how an order should look, right? When it comes to PRN pain medication. So hydromorphine. So this is um, an order that says 2 milligram tablets PO every 4 hours, PRN for mild pain. So whenever you have a PRN order, you have to have indication of exactly how much, when can I give it, and what circumstance can I give it under. And if you have the word mild pain, there might be a policy that indicates mild pain is anywhere from 3 to 5, right? Or and then 6 to 8 is moderate, and then anything above 9 and 10 is considered severe, right? So as long as you have a policy to that states, okay, this is a score I receive, and this is considered mild, then you can do it. But if you don't have that, then the physician has to not write mild pain; they have to actually write for score or pain of 3 to 5. Okay. Morphine, as you can see here, the problem with this one is giving you a range. Okay. So it's also saying severe. So we need to know what is severe. And then from 2 to 4, you need to know exactly, all right, 2 or 3 or 4. So they can't write ranges like that. It has to be specifically, because if you administer 3 or 4, you can say, well, I was covered by the order. Really, you're practicing out of your scope of practice, and you are now making the prescribing decision, and that is on the physician, right? So they need to decide, we want to give 2 for mild, 3 for moderate, and four for severe. And that's probably what they're thinking, right? Um, but they need to write it as such. All right. So let's go back to, so that was my little spiel up here as far as saying within your scope. All right, and your MD orders. So now let's talk about our co-analgesics, and let's talk about our common medications. So here we have obviously morphine, and that would be a pain medication. So that's a common medication that we use along with fentanyl, Dilaudid, and methadone. And then we have our common medications that we use along with them is Zofran. So we use Zofran. We know it's for as an anti-memic, and that helps to keep away any type of nausea and vomiting. We have Tylenol, right? So Tylenol can help with any inflammation that's going on while you're also giving morphine. So I want to stop right here and just let you know that morphine and Tylenol, and this is the Tylenol, this is rectal Tylenol that we give. And I think I talked about, we give a lot of rectal stuff, and Tylenol is one of them. Tylenol comes oral. You guys know that, tablet, rectal, and IV now. So Tylenol can be given in multiple ways. But when you give morphine and Tylenol together, they work beautifully. I'm not a big fan of morphine. It has a very short half-life, and has lots of nasty side effects. Um, and it only usually lasts maybe 2 hours. But when you give Tylenol and morphine, basically it can lengthen morphine's effect for like 4 hours, and I love it. It's a great, great trick. What else do I have here? Oh, I have Versed. So Versed is there. Obviously, that's an for anxiety. So it's a benzo, and it is great for people who are anxious as well as in pain. So we can give them that as well, but we also need to watch the respiratory system too, right? Gabapentin is there because gabapentin is used for chronic long-term pain, but it's a great drug that we can use in addition to some of these other medications that we commonly give for pain to get them off of these and just put them on a long-term pain medication. All right. And then I also have some others here like steroids like Decadron, clonidine is helps, which is catapress to help them relax a little bit. Let's see what else. Toradol, Motrin, if they can get Motrin and stuff like that. All right. So let me know if you have any questions about this. It is very good to make sure you understand when you're giving an opioid, whether you're giving a co-analgesics or the adjunctive drugs. Um, and that you give them to support the use of these drugs, right, to deal with any possible side effects of these drugs. And that is why we use these drugs, when I say these drugs, I'm talking about the co-analgesics, when we're also going to be using a pain medication. And there's also another thing, and I don't think it's listed in the next slide, so I'll talk about it here. This is the preemptive analgesia. Preemptive analgesia. So preemptive analgesia means that you're going to go ahead and preemptively give kids pain medication knowing that they are going to have pain. We do not wait until a child is in pain. First of all, they may not tell us until it's really, really bad. So a lot of times, especially neurosurgery, they will go ahead and order something around the clock. So there will not be a PRN order. It will be a routine scheduled Tylenol and Motrin around the clock. After surgery, certain things we will give morphine or fentanyl or whatever around the clock for the first 24, 48 hours. That's called preemptive analgesia. We are going to give these drugs regardless, because we do not want the child to experience any type of traumatic pain. And we know that they may have a very difficult time communicating to us that they have pain. That's a big difference from when you're in acute adult acute care. They want us to call them when we want pain medication. And we most likely can do that when things start to hurt. But children, it's different. And so you will see routine drugs given around the clock, and we will not be using those tools. We will not be using um, an assessment. We're going to go ahead and give it, and that is an approach that we use in peds. There's another thing we use. You probably are familiar with. It's called Elmo cream, and that's lidocaine, basically. That is placed over areas that are probably going to have a procedure done or an IV started. And so, like for this child, the Elmo cream is placed where he's going to have a lumbar puncture done in the morning. Ammo cream is great. It will numb the area, but it has to stay on for a particular good period of time in order to get a good numbness. So in the ICUs and EDs where they might need to get access much sooner, they might use different techniques and it's not used as much. But this is great for like a med surge situation, and they know they're going to have the procedure in the morning, and the nurse will just put that on and put a Tegaderm on top of it, and it nicely numbs the area. Elmo cream is a great cream to use in peds. All right, so this is going to talk about, and I think this is the last slide for this section, other techniques that we use, other things besides drugs. So we have the biobehavioral methods where we use different things to kind of distract them, and they don't realize it what we're doing, but it so we don't have to use these drugs, right? They can get through this procedure without these drugs, and we don't have to sedate them. So I'll talk about some of them. Task analysis. I do task analysis all the time, and this is the giving the child a task. So, like when I'm taking out an IV, there's going to be a little bit of discomfort with that. Um, but if I give them the job where they're peeling up little sections of it by themselves, because they're peeling up some of the sections, it doesn't hurt. But if I peel it up, it hurts. And giving them a task is one way to minimize having to make a big ordeal over taking out an IV, or making it not hurt so much, guys. Distraction, looking at something else while we're doing whatever we're doing. Usually, child life is really good at that. If they can cooperate with deep breathing and relaxation, that would be a great way for our teenagers and our older children. Using biofeedback as well. Positioning. I cannot express the importance of positioning, especially if they are injured or post-op and they have been sitting in that position all the time. And people aren't realizing, like, if you really change the position of your patients, they will rest better and they won't have as much discomfort. Um, and then sweeties. So sweeties, let me see here. So continuous stimulation is like a vibrator, like the buzzing bee in an area. So they focus on like the sensation of the vibration instead of the sensation that you are causing in another area. But sweetie, so this is a good picture of sweetie. So I used to put in pick lines. So I would be this person over here, while somebody else is using this sucrose solution and they're putting it on the pacifier and giving it to the child. It gives this euphoric feeling to the child. It's like a high, I mean, it's a major high for them, the sweeties. It's a sugar rush. They actually become very addicted to that stuff, FYI, if we give too much. So there are some sweeties protocols in the NICU. But anyway, all that to say is that during a procedure, where somebody's putting in a PIC line or doing something, if we give a neonate sweeties, they'll focus on the sweeties and won't even know that we're giving them an IV or sticking them. It is fantastic. All right, so back to this atraumatic care. I told you I was going to talk about it, in pain. And so we're end with this saying that, it is really important for us to take always an approach to minimize any type of prolonged pain, um, multiple pain, and obviously some injury, because sometimes these things can also cause injury. Some of the main causes are needle stick pain. So that is the heel sticks, the finger sticks constantly, postoperative pain, not using the preemptive analgesia, not measuring things properly or adequately and reassessing, and not using, combined or evidence based. These are some of the things that can cause traumatic care to kids, for different reasons and can injure them. And I'm not talking injuring them physically, I'm injuring them with their trust and ability to cooperate in their care, in the future, both then and in the future. All right, so this concludes this lesson. If you have any questions, please let me know.